I'll be speaking on long-term outcomes of therapeutic corneal transplants performed in tertiary care hospital in South India. So infectious keratitis in India is 10 times greater compared to other developing countries. Other developed countries, and the incidence rate is about 1.5 to 2 million cases added, and this is added annually to the existing numbers. And there is a significant number of such corneal blindness are mainly due to infectious keratitis because of perforations as well as loss of globe integrity. Corneal infections are 63.6% and is a most common indication for TPKs. And this is an overview of the 15-year statistics of the keratoplasty at our center, and 2016 is the year that is considered for the study. It shows about corneal ulcer of 1,141 with a TPK done about 196. Now, the purpose of the study was, the primary objectives were to find out the outcomes of TPK, that is anatomical, therapeutical as a functional level at 6 months as well as 3-year follow-ups. And the secondary objectives that were done were mainly compliance to the follow-up, uptake of the optical grafts, as well as how effective it was in eradicating the corneal blindness. The methods that were done was a retrospective chart review of all patients who underwent TPK in the year of 2016 in Hyde Hospital, Pondicherry, and there was about 196 TPKs done and about 140 optical keratoplasties done. But even though even though there was 196 TPK, the sample was only taken for 149 grafts among 135 patients, because based on the case records that are available. So the outcomes measured were the anatomical success was based on the grafts that retained the tectonic integrity for the globe after TPK, and therapeutic success, grafts that achieved healing after TPK, and functional outcome. The results include, it was 85 were males and 50 were females, and mainly was in the age distribution of 41 to 60 years. The preoperative features, in which the most common visual acuity they were presenting was hand movements, and perforations were among 65 of them. And the time between the temporary stabilization, that is through glue BCL, to surgery was 6 days, and the time for decision making to performing of the surgery was 4 days. So of this TPK, all the TPK done, the therapeutic purposes was 8 for 80 purposes, tectonic was 7.5, and 1 was done for as a therapeutic DAL because it only involved the anterior stroma, and re-TPK was about 12.1. This was a graph showing the the indications of TPK, and infections were non-traumatic perforated ulcer was the 66 of them. And the most common infectious etiology was in bacteria, that was Pseudomonas, as well as in fungus was Fusarium as well as Aspergillus. So of 89% of TPK, that was with the primary success, for 41% underwent primary success, and 44 had an additional intervention done, such as intracameral voriconazole and moxie given, or even core vitrectomy done, and 11 underwent repeat TPKs, of which 1 had underwent evisceration. So this was the anatomical outcomes at the and functional outcome at 6 months and at 3 years. So the graph status was that. Should I continue? Okay. So the graph status was that about all the TPK done, 89% had a failure, and only 11% had a functionally optical graft. And of the follow-up, we see that at the end of 6 months, there were 1 or 2 patients, but at by the time it reached 3 years, it was only 32 patients left. And optical regrafts that was done for only 23% of the cases. And those who went for secondary complication were the following, based on endophthalmitis, glaucoma, and leaf graft infection. Of the total graft outcomes that was seen after 3 years, there was 62% failed, and of the 38% that had a clear grafts, that had about 74% who underwent a optical keratoplasty for the functional outcome. This was based on comparison to other studies. So, for a good therapeutic and anatomical outcome of the TPK, the therapeutic success was only 89%, and the anatomical success for maintaining the integrity of globe was 86%. And this was comparable other studies. Even though there was an overall graft outcomes based on function was poor because of the poor quality of the TPK graft that was used in the study. And there was a high number of perforated cases because they have come for late presentation and poor graft quality that was used. But however, there was no steroid that was used because even though there was no steroid use. Now, the poor follow-up rates among keratoplasty patients were 85% followed up till 6 months and only 31% followed until 3 years. And they were in the low socioeconomic group, and major problem was a functional impact. And there was poor uptake for optical keratoplasty, and only 23% underwent optical keratoplasty. So, to conclude, there was for preventing, there will be strengthening of the primary care treatment, and awareness programs should be conducted among public and doctors, and treatment based on the decision for the right time to take up for TPK and efficient usage of donor tissue, that is either for lamellar or gamma irradiated grafts. And visual outcomes was to prioritize for optical keratoplasty and drug-eluting sutures. Thank you.
All the speakers, please stick to your times so that you will lose your, if you cross the 4 minutes, that definitely you will lose your marks. So because give us to ask 1 or 2 questions, Anna. So when you cross your 4 minutes, then we don't have time to ask. So basically it's okay. So I have one question for you. So this is all about the descriptive retrospective data analysis. So can you give me one example of the limitations, the biggest challenge when you analyze the data, retrospective data? So what is the challenge?
So the main problem was no, we were not able to take up all the patients that was included in that year of 2016 because the case records were not available, and the follow-up was difficult because the patients did not follow up, and at the end of 3 years only 32 patients we could assess the outcomes. So that was one of the drawbacks or limitation of this.
Yeah, so just for the education purpose, yeah, that's okay. So for retrospective data analysis, the biggest challenge is because data is so incomplete. You know, so when you want to do an advanced analysis in terms of logistic regression, multivariate analysis, we do not have a data. So there is the biggest challenge, biggest limitation when you analyze the data retrospective regression. For prospective, you can think of what are the, I mean, according to your needs. So to me, that this is the biggest limitations. You do not have a data, complete data to analyze further. Thank you.
Thank you, Dr. Megha.
Good afternoon, everyone. I'm here to present our study on corneal topographic changes before and after pterygium surgery using corneal tomography. Pterygium is a degenerative ocular surface disease characterized by a wing-shaped fibrovascular connective tissue overgrowth of conjunctival and limbal tissue onto the adjacent cornea. Pterygium causes flattening over the nasal and temporal paracentral area in the horizontal meridian. As pterygium causes optical irregularity, it can also induce corneal wavefront aberrations, which might not always cause visual impairment but can lead to significant subjective visual complaints such as glare and halos, even in patients with best corrected visual acuity. Conventionally, we use keratometer to record the radius of curvature of the anterior corneal surface. But keratometer just usually measures the fixed card length of 3 mm, which comes in the central optical zone, and it fails to identify changes in the peripheral cornea. So we have evaluated the preoperative and postoperative changes in corneal astigmatism using Pentacam, a Scheimpflug imaging system for anterior segment analysis. Our aim was to study the corneal topographic changes before and after pterygium surgery using corneal tomography. Our primary objective was to assess the corneal astigmatic changes, and our secondary objective was to assess the higher order aberration in the central 6 mm of the cornea before and after pterygium surgery using Pentacam tomographer. We included 85 patients in the age group between 22 to 55 years with primary nasal and primary temporal pterygium. We excluded patients with double pterygium, recurrent pterygium, those with previous history of corneal trauma, previous ocular surgery, corneal scarring, dry eye, and systemic autoimmune disease. We preoperatively measured the best corrected visual acuity for distant vision using a logMAR chart, and using pentagam we recorded the keratometric value in the flat meridian, steep meridian, mean keratometric value, keratometric astigmatism of the anterior corneal surface. And using pentagam we recorded the higher order aberration by root mean square in central 6 mm of the anterior corneal surface. Measuring the size of pterygium using calipers from limbus to apex was done intraoperatively. Pterygium excision with a limbal conjunctival autograft using fibrin glue was done. 6 weeks post-operatively, we followed up the patient. As seen, the prevalence of pterygium increases with the age, and the mean age was around 45 years. And the prevalence of pterygium in our study population was more in female patients. All our 85 patients had a primary nasal pterygium, which confirms the hypothesis that 90% of the pterygium occurs in the nasal conjunctiva because it receives a more solar ultraviolet radiation from the reflected nasal bone. We divided the group into two, the size, depending on the size of the pterygium. Group A included patients with 1 and 2 mm pterygium, and Group B included patients with 3 and 4 mm pterygium. And we compared the best corrected visual acuity, corneal astigmatism, and higher order aberration. We compared the mean preoperative and postoperative astigmatism difference between Group A and Group B, and Group A showed a significant decrease. The same way we did for the higher order aberration, and Group A showed a significant decrease. There was a statistically significant improvement in visual acuity and a decrease in corneal astigmatism before and after pterygium excision. And there was a statistically significant reduction in pre- and post-operative higher order aberration in the anterior corneal surface. Conclusion: successful pterygium excision can lead to improvement in corneal topographic changes induced by pterygium. It can lead to improvement but not complete reduction. Earlier excision of pterygium results in lesser residual postoperative corneal astigmatism and higher order aberration. Cataract or refractive surgery in a patient with pterygium should be planned after pterygium excision and stabilization of corneal topography. The corneal topographic analysis gives valuable information to patients with pterygium, so it should be included in the routine clinical evaluation. Thank you.
Doctor, you are not a ratified member, right?
No, sir, I am not a ratified.
So how did you do your follow-ups? At what period of time you have done this corneal topography?
After surgery, we'll call the patient after 1 week. But the study period was like after 6 weeks. We'll call after 6 weeks.
So after a patient completes 6 weeks after surgery, you are doing that.
We'll measure the
So
post-operative.
did you find any difference at 1 week? Then directly you called it 6 weeks, or in between also you had called it 4 weeks or so?
No, ma'am,
And did you
directly
find any difference
at
in that?
6 weeks.
Okay.
Patient follow-up was a difficult one, so we had only one follow-up at 6 weeks.
What's you in your study?
Like we have evaluated the higher order aberration changes also. In certain patients, even if the pterygium is not involving the visual axis, the patients might have a significant visual complaints like a glare halo. So in those cases, instead of we can go for the corneal topographic analysis with the stomography to evaluate for that higher order aberration, and if it is significant, we can proceed with pterygium excision even if it is not causing reduction in best corrected visual acuity.
Okay, thank you.
Thank you.
Very good afternoon to all. I will be talking about iridocorneal endothelial syndrome, multiple windows in iris. Iridocorneal endothelial syndrome is a rare condition. It can be challenging for ophthalmic surgeon to manage. It is characterized by proliferative and structural abnormalities of corneal endothelium, progressive obliteration of iridocorneal angle, iris anomalies such as atrophy and polychoria. It is sporadic in presentation and it is usually unilateral. Coming to the case, 35-year male farmer hailing from Anand, Gujarat, came to OPD with the chief complaint of diminished of vision and halos in left eye since 4 months and pain in left eye since 4 months. He was apparently alright 4 months back when he noticed diminished of vision in left eye, gradual in onset, progressive in nature, associated with pain, pricking in nature, and present throughout the day. There was no aggravating and relevant factors. Patient had shown to the ophthalmologist elsewhere, underwent laser peripheral iridotomy, and was prescribed following eye drops, moxifloxacin, dexamethasone, Dozos T, and CMC eye drops. There was no significant past history and no significant family history. General examination and systemic examination was normal. External examination was also within normal limit. Visual acuity in right eye was 6.6 with near vision N6, and in left eye it was 6.18 with best corrected visual acuity, and near vision is N24. Slit lamp examination in right eye was within normal limit. Intraocular pressure was 14 millimeter of mercury, and fundus was also show 0.4 CDR with full dull foveal reflex. In left eye, there was a congestion and circumciliary congestion. There was a mild corneal edema. Multiple iris atrophic patches we can see in the picture. There was a peripheral iridotomy present at 11 o'clock position. Full thickness iris holes are present at 6 and 8 o'clock position. There was a pupil was oval, which is stretched superiortemporally, and it shows sluggish reaction on light. AC depth was Van Herijk's grade 3. On gonioscopic finding, peripheral anterior synechiae present extend beyond the Schwalbe's line, and it is present nasally and temporally. Specular microscopy shows loss of hexagonal shape and eye cells, that is darker in appearance, and central light spot area surrounded by peripheral clear region. We had given a treatment of timolol maleate 0.5% eye drop, which is beta blocker 2 times a day, and sodium chloride 6% eye ointment at night. And we advised follow-up after 2 weeks. Then patient lost follow-up. Iridocorneal endothelial syndrome represents a spectrum of disease. These variants are linked by fundamental defects of corneal endothelium. Altered endothelial cells also secrete an abnormal basement membrane. Contraction of these basement membrane leads to iris changes, iridotrabecular synechiae, and secondary glaucoma. Visual loss is secondary to other corneal decompensation or refractory glaucoma. This shows 3 variants: Chandler syndrome, progressive iris atrophy, and Cogan-Reese syndrome. All this shows iris atrophy and variable corneal edema. Management depend on medical and surgical. Medical treatment, anti-glaucoma medications and hypertonic saline. Glaucoma surgical management include trabeculectomy with antipyretic agent and glaucoma drainage device. It is difficult to maintain long-term success as the fistula and trabecular meshwork can be obstructed with advancing abnormal corneal endothelial cells. Cornea surgical management include penetrating keratoplasty, DISSEC and DMEC after resolution or in advanced cases of corneal edema with controlled IOP. Take home message: it is a rare disorder characterized by structural and proliferative abnormalities of corneal endothelium, anterior chamber angle, and iris. There is no single intervention that can treat the condition for entire lifetime. Treatment of iris-related glaucoma require filtrating surgeries. Visual impairment and pain associated with corneal edema can be successfully managed with endothelial keratoplasty, and frank discussion with the patient is required about the disease process so that appropriate expectations are set. Thank you.
So what was the management in your patient?
We have given a timolol maleate eye drop 0.5% and sodium
Only
chloride.
the medical management.
Yes, ma'am, we had advised follow-up to the patient, but he lost follow. Thank you. No, we had not done. It is previously done elsewhere.
Just a comment. When you were telling the history, you said a brand name actually. Don't tell the brand name.
Okay.
Dorzolamide plus
Yes.
Solol you should
Yes.
tell,
Yes,
not
sir.
tell the brand.
Okay, sir. Thank you.
So the next presenter is
Good afternoon all. I have a case report of Sodomsopal keratitis, and Calotropis procera is a flowering shrub belonging to the family Apocynaceae and abundantly grown in Indian subcontinent, and it also known as Sodomsapple, solanwort, and milkweed and madar. And exposure to Calotropis latus is common occurrence where religious festivities prefer to the use of garlands. So it contains the stages of it can be a stage acute acid injury can be with pain and respond to the acidity of the sap. So the symptoms will be burning, irritation, lacrimation, photophobia. It can present with a stage of without pain also due to the toxic effect of the latex on ocular tissue, inherent analgesic property of the sap. So symptoms will be only the decreased vision. So this stage, then next stage, it can be cause only the Descemet membrane fold due to toxic effect. That latex can penetrate the intact cornea and produce permanent endothelial damage. So here the symptoms also will be diminution of vision. So here a 67-year-old male, he came to OPD with the diminution of vision and colored halo since 1 day, and there is no pain. And recently he has undergone a cataract surgery two months back, and his best cataract visual acuity in both eyes was 20/120, and IOP in both eyes was 16 mmHg. So here anterior segment examination right eye shows there is a mild congestion, mild circumcorneal congestion with diffuse Descemet fold, and that temporally and nasally the few stains are taken in the conjunctival part with punctate mild erosion in the cornea, and OCT shows the DM fold with mild corneal edema. The anterior segment of the left eye shows the same as the right eye with a diffused DM fold with corneal edema with punctate staining positive in the cornea, and here also the OCT picture shows the Descemet fold with mild corneal edema. So we are treated with penicillin assisted 1%, 4 times a day. We have tapered 3 days per week, and he was reported to the hospital after 2 days, and his visual acuity was improved to 6/6 with no Descemet membrane fold. And we are not able to take pachymetry and corneal endothelium count. So calotropis procera latex can present with a varied symptoms and ocular examination findings. So management depends on the time of presentation, and irrigation with 500 ml ringer lactate with no benefit after 24 hours. So if acute presentation, if with pain, we can give a wash, and with litmus paper we can see the severity of the acid. If it, till the litmus paper is not turned to red, we have to give the wash, and to confirm the remove the toxins, and it will decrease the absorption too. And the sap of the calotropis procera has been found to contain histamine and prostaglandin, which may lead to the iridocyclitis. So the latex of calotropis procera contain several alkaloids which are causatic and considered poisonous in nature. So profound fall in the number of corneal endothelial cells. The ocular lesions are easily preventable by increasing the awareness and wearing protective glasses. These are my references. Thank you.
Have you ever tried to compare your medication, like you have used the prednisolone acetate, and with low dose steroids, low potent steroids?
Actually, this was like a study of case series. Before collecting the cases, I have posted 1 year back. So now we have a lot of cases is there. So we didn't tried low dose steroid. Just if we will be
Because
adding
I have
antibiotic.
seen patients who get cured with low potent steroids also. So rather than exposing them to a higher potent steroid, which can cause raise in IOP if he is a steroid responder.
Usually it will be present with inflammation and maybe some discharge first day. So that time we will be starting only with antibiotics. The most of the times in 1 day it is getting cured for some patients. So if anti-segment inflammation or AC inflammation is there, we are going with the steroids. If Descemet folds is there, we are going with penicillin acetate only.
But it is not. Yes, it usually cures, right?
Yes, ma'am.
One day.
There is no discharge, was there, no inflammation, so we stick only with the steroids. Because this patient is 2 months history of recent cataract surgery, so we stick on the steroid.
Whereas if the presentation is there and you can decrease the toxin by ringer lactate, then you put that patient on further treatment. Have you seen any changes after that?
Usually patient will be coming within 24 hours.
So the next speaker is
Good afternoon, everyone. I'm going to present a case of secondary optic nerve atrophy, secondary to a rare infectious cough. We got a patient of 30-year-old male presented with complaints of decreased vision in both eyes for 1.5 months, which was sudden in onset and painless in nature, and it is not associated with any other ocular symptoms. No history of smoking or alcohol, no history of trauma, no history of any complaints of reduced vision in the past, and usage of any spectacles. Previous medical history said that patient has a history of fever, altered sensorium, and fever, for which he was hospitalized for 2 months and on tablet doxycycline and steroids. On ophthalmic examination, his visual acuity of continuing at 3 meters with no improvement on pinhole test and with glasses in the both eyes. And on torchlight examination, there was sluggish pupillary reaction to the light and nystagmus are noted. Extraocular movements are full and normal. On slit lamp biomicroscopic examination, anterior segment is within normal limits with normal intraocular pressure. On evaluation of fundus, both eyes revealed temporal disc pallor and with dull foveal reflex. On OCT on optical coherence tomography of optic nerve, we got there was RNFL thinning in the both eyes is noted, and also the macular thinning in both the eyes, and with right eye subretinal fluid also is present. These are the pictures of different radial line scans. On fundus fluorescent angiography, there was enlargement of foveal avascular zone, which indicates macular ischemia, and visual fields could not be done because of nystagmus. And hence, based on this history, examination, OCT, and FFA findings, we reached a probable diagnosis of optic nerve atrophy with macular ischemia in both eyes. Based on only ocular examination, the differential diagnosis are post-infectious optic neuropathy and neuroretinitis, or post-papilledema, a traumatic optic neuropathy, or nutritional or toxic optic neuropathy. The lab investigation when hospitalized was done on complete blood count, which showed thrombocytopenia, and serology, which was negative for dengue, HIV, and HPS, and it is positive for Weil-Felix test, that is rickettsial infection. And diagnosed to have meningoencephalopathy and thrombocytopenia secondary to rickettsial infection. The patient received appropriate treatment along with platelet transfusion and was discharged after his vitals were stable and platelet count were normal. After the systemic investigation, we came to the diagnosis of optic nerve atrophy with macular ischemia secondary to any rickettsial infection. Coming to the discussion, rickettsiosis is caused by rickettsia, which are obligate intracellular gram-negative coccobacilli, and it is transmitted to the human through infected arthropods such as mites and ticks. The rickettsiosis produces occlusive vasculitis by infecting smooth muscle cells and endothelial cells of capillaries and small arteries and veins, which causes increased vascular permeability, fibrin and platelet deposition, which cause occlusion of blood vessel, and which results in death of tissue. The ocular manifestation which were reported before or by vitritis, retinal lesions, retinal vascular leakage, and optic disc swelling and optic neuritis, which are of rare occurrence. In our case, patient presented to us 2 months after the onset of his fever with pale disc, suggestive of secondary optic atrophy, most probably due to direct invasion of microorganism. Weil-Felix test, which is considered more than 1:80, is positive. Conclusion: it is important to do an ocular examination in a patient who presented with history of fever. Hence, it can be diagnosed and treated early to avoid irreversible vision loss due to optic nerve damage and macular disease. Thank you.
Where you see a bilateral optic atrophy like this, would you not consider doing a VEP in such a patient to know the visual loss?
Yes, ma'am. But he didn't come for the follow-up again, so we didn't do the proper, fully is not investigated.
And beyond the Weil-Felix test, is there no other supportive test which suggested you that you were very sure that it was rickettsial?
RT-PCR can be done.
Right.
PCR can be done.
Yes.
Imaging was done?
Neuroimaging MRI was done, sir, but he didn't have the report. It was done outside. We had that prescription of the doctor, so it says encephalopathy. We didn't have that proper MRI report.
Why there was nystagmus? You said there was nystagmus.
Yeah, yes, sir. He got nystagmus after that encephalopathy only. Might be due to brain lesion.
Okay, thank you.
Thank you.
So the next speaker is Dr. Samvedya. Presentation is she will come later. Please switch. Dr. Amol Gauri. Dr. Amol Gauri.
Hello, my name is Dr. Amol Ganvir. My topic is pigmented paravenous choroidal atrophy and multimodal imaging in it. Introduction. PPCR is characterized by the RP degeneration, choricapillary atrophy, and pigmentation along the retinal veins. The retinal atrophy is characterized by the loss of outer segment of photoreceptor, outer nuclear layer, inner nuclear layer. Though the etiology is not known, the many inflammatory and infectious causes have been associated with the disease, including sarcoidosis, Behçet's disease, syphilis, measles, rubella, and tuberculosis. Fundus autofluorescence, structural OCT, OCT angiography, ERG are used to find out the details of the disease. There is no specific treatment to it. My purpose was to analyze the clinical features of PPCRE by OCT angiography, structural OCT, FFA, fundus autofluorescence, and ERG. So, 18-year-old female patient came for routine eye checkup. We incidentally discovered the bony speckle along the retinal veins in the both eyes. Patient was a known case of TB. We made a clinical diagnosis of PPCRE. Patient had a normal color vision, night vision. The both eye base corrected vision was 6/6. Anterior segment was normal on slit lamp. We performed autofluorescence, OCT angiography, structural OCT, full field ERG, and visual field. So this is the right eye fundus photo, which shows the pigment clumps at the paravenous area. The fundus photo of left eye, which also showing the pigment clumps over the paravenous area. This is a fundus autofluorescence, which show the hypoautofluorescent area, which correspond to pigment clumps. This is the ERG findings. The pattern ERG, which show reduce the P50 response and P95 response, which P50 response is basically a suggestive of macular photoreceptor, purely cones, and N95 suggestive of mostly ganglion cell dysfunction. The light adapted ERG, which shows the reduced A and B waves, which basically which suggestive of reduction of cone response and inner retinal layer response by B. The dark adapted ERG, which shows normal ERG. A visual field shows a localized scotoma, which correspond to the lesion. OCT macula was normal. Inner retinal layers and outer retinal layers was intact. This was the OCT we took over the lesions, which shows the absent of the nerve fiber layer, alterations at the ganglion cell layer. Hyperreflective foci was seen in the mostly in inner retinal layers. Absent of ellipsoid zone, the RP atrophy and absence of choricapillary layer. The OCT over lesion, which correspond, which showing same findings. There is the whole eye angiography of right eye, the OCT angiography of whole eye for right eye, which showing the flow wide area along the paravenous area. This is a superficial plexus, which showing the altered vessel density and flow wide areas, which corresponding to pigment clumps and around the paravenous area. This is the superficial plexus over the macular lesion, which looks okay. This is a deep plexus over the macular lesion, which show some flow wide area over here. This is the outer retinal choricapillary slab, which showing the flow wide areas around the paravenous lesion. The choroid, which shows the lesion which corresponding to choroid atrophy. The choroid, the choricapillary lesion over the macula, which shows some flow wide areas. These are studies which conducted which state the importance of multimodal imaging in PPCRA cases. Mostly OCT-A finding, which previous in study suggested altered vessel density in the deep capillary plexus, choricapillary region. And this study, Ratnesh Ranjan suggested normal flow at superficial and deep capillary plexus and choricapillary. But in our study, we found flow wide areas in superficial plexus area and altered vessel density also, and few alterations at the deep plexus and choricapillary slab. From that conclusion, we concluded that multimodal imaging is important to in PPCRA case to know the severity of disease, though there is no grading for severity. OCT angiography demonstrates the impairment at the level of choriocapillaries and superficial capillary plexus and few alteration at the deep capillary plexus, which could have created the changes in the nerve fiber layer, ganglion cell layer, outer nuclear layer, and outer plexiform layer. Alteration at the level of choriocapillaries in the OCTA and choroid thinning in structural OCT may represent the key factor in the pathogenesis, which is not known properly. So limitations of our study was only single case study. So that's why we do not conclude our finding and confirm. Need long follow-up to know disease course, and OCT angiography was not done on follow-up because it's a costly suggestion. Further studies are warranted to analyze the vascular alteration occurring in PPCRA or longitudinal follow-up. Thank you.
So next presentation will be by Dr. Apurva Adhikari.
So good afternoon, everyone. It is not. So good afternoon, everyone. My topic is uncomplicated but significant. Today, using computer is the order of the day. So I am working in a government setup. So we are seeing many patients with computer vision syndrome. Basically, not moving. Basically, symptoms are asthenopic, there is eye strain, tired eyes, accommodative symptoms, and other is ocular surface related, like dry eyes, watering, irritation, redness, gritty sensation, these symptoms, and non-ophthalmic symptoms are there due to sitting in a position for a long time. Backache, nape of the neck pain, and headache like things. Root causes is a prolonged period of looking at desktop, laptop, leading to compromised tear film sitting in the same posture as I mentioned, and inability to relax the accommodative system. 200 patients who are all employees in a government organization came with various symptoms like backache, pain in the nape of the neck, apart from common symptoms like pain, redness, itchiness, watering of the eyes. And the study period is more than 1 year, from April 2021 to June 2022. Material method, they have been routinely examined by slit lamp, applanation, Sharma test 1 and 2, tear film breakup time, and refraction. Patients are primarily treated with anti-inflammatory decongestant eye drops, dry eye relieving eye drops, and spectacles with various options, including the progressives. The results around 80% of the eyes recovered with the treatment options mentioned. Some patients had refractive error, which was not known to them. That is surprising. 15% of patients developed chronic dry eye symptoms, which were difficult to alleviate with usual dry eye medications. Discussion: a sizable number of patients needed treatment for dry eye symptoms for a prolonged time, more than 1 year. Around 15% of patients needed 2 or more dry eye medications on long-term basis, which add to the considerable cost and loss of productive hours. Conclusion: computer vision syndrome is an important clinical condition and may need adequate care early in the course of symptoms in a patient, and also in refractory cases needs very long-term treatment to prevent productivity loss and cost reduction in an organization. Thank you.
So what is the incidence of computer vision syndrome? So I do not see that incidence.
Basically,
time frame of
basically we are dealing with the government employees, and we found at least 15% roundabout patients of the employees are suffering from this.
Then
And
the lens, what is the time frame that you follow up? Go to
all the patients are followed up more than 1 year.
more than
More than 1 year.
More than
1 year, 2 months like that, from April to June 2022.
okay, so the incidence found to be 50%,
Not 50, 15.
15.
Yes. And the surprising things are that many of them didn't knew that they have glasses.
So can it be representative of the general population because you are confining to the
Yeah, maybe because we are dealing with the productive year individuals, 25 to 55 like that. So it may be correlated with the general population also.
How important, sir, is the lifestyle change for these patients?
Yeah, that's a very an important question, and we repeatedly tell actually employees, yeah, please get up at least for 2 minutes from your seat. Go to the washroom and have a splash of water like that, and then came back to
So there's something called as a rule of 20 for these patients.
yeah, 20 is there, but not possible in every setup. But at least they get 10 minutes. Still, it will be working, I think.
The study was done entirely in the COVID second wave time.
Actually, 2021 April I started, and patients were taken up to June 2022.
The second wave of COVID.
Yeah, yeah. Thank you.
So the next speaker.
Good afternoon. Glaucoma diagnostic accuracy of macular ganglion cell layer versus retinal nerve fiber layer thickness. The aim of the study was to evaluate the accuracy of macular ganglion cell layer thickness obtained by macular retinal layer segmentation software of Spectralis SDOCT in comparison with circumpapillary retinal nerve fiber layer thickness in discriminating normal and glaucomatous eyes. The design, it was a prospective cross-sectional observational study. 100 patients diagnosed with primary open-angle glaucoma and an equal number of healthy adults without glaucoma served as controls. For imaging the macula, using the posterior pole horizontal scan protocol, layer-by-layer segmentation was performed with the new software for Spectralis SDOCT. Optic nerve head, radial scan and circular scan protocol was followed to image the optic nerve head and peripapillary region. The macula has several potential physiological and anatomical advantages for glaucoma detection. The underlying pathology in glaucoma is retinal ganglion cell loss. Therefore, direct measurement of RGC loss can be a powerful method for early glaucoma detection. The results of the study, GCL thickness parameters and CP-RNFL thickness parameters were combined and the AUROC compared to determine their diagnostic capacity. CP-RNFL global average thickness had the highest diagnostic capacity with an AUROC of 0.816 with a cutoff value of 90. This was followed by GCL outer temporal zone with an AUROC of 0.796 at a cutoff value of 31. There was no statistically significant difference between them. This table shows the grading of diagnostic performance of GCL layer and circumpapillary nerve fiber layer parameters. As you can see, CP-RNFL global had the highest AUROC of 0.816. This was followed by GCL outer temporal quadrant with an AUROC of 0.796. This image shows the AUROC of macular GCL and CP-RNFL. As you can see, CP-RNFL, this is the curve which is the highest at the top left, closest to 1, had the highest diagnostic capacity, and it was followed by GCL outer temporal quadrant. The conclusions of our study. Though in most studies, CP-RNFL thickness superseded macular GCL thickness in its diagnostic capacity of glaucoma, in certain clinical situations, macular GCL proved to be more reliable. CP-RNFL thickness measurements with SDOCT is limited by significant variations in the shape and size of the optic nerve head, as you can see in these images, refractive error, axial length, and peripapillary atrophy, as in high myopia. However, these disadvantages can be overcome by macular GCL measurements, and macular measurements are less influenced by the optic disc size and the results are more authentic. The coefficient of variation of retinal cell density in the fovea of normalized is less than 10%. So low variability indicates low threshold of abnormality. And the RGC layer in the macula is less variable than RNFL and optic nerve head. Hence, these changes in the RGC are more likely to be pathological than normal variation. So this fact paves the way for detecting glaucomatous damage at a very early stage, sometimes 5 years before functional damage can be detected. To conclude, our study showed that the ability of segmented macular GCL thickness to discriminate normal and glaucomatous eyes is high and comparable to that of CP-RNFL. GCL thickness measurements did not outperform CP-RNFL thickness in the diagnosis of glaucoma. However, in certain clinical situations, as described above, especially in early glaucoma, macular GCL thickness could prove to be a more sensitive diagnostic tool for glaucoma. Thank you.
So when you did this, there is a test called as the microperimetry also for the macula, the central macular layer. Okay, so when you did this test for your patients and you found out that the retinal ganglion cells in the macular area, did you come across patients which you followed up for many years and over a period of time and realized that they you probably thought that they were potential patients for glaucoma damage, and did the damage progress? Did you see such patients?
Ma'am, this was because this was a cross-section study. We just took it at one point of time. But practically, I have seen that the GCL gradually reduces, and that in early glaucoma, the macular GCL values are more important and more diagnostic. But in advanced glaucoma, CP-RNFL has a better diagnostic value. So long-term studies have showed that in early glaucoma, actually a combination of macular GCL and CP-RNFL together will give a high diagnostic value. But like in certain cases, especially like in high myopia when there's peripapilar atrophy, the CP-RNFL values will not be reliable. Such cases, macular GCL is more reliable.
So we'll move.
Good afternoon. I'm presenting a paper on Cox retinal vasculitis, myself Samvedya. Retinal vasculitis is a sight-threatening inflammatory condition of the retinal vessel associated with perivascular sheathing, vitreous cells, cotton wool spots, and intraretinal hemorrhages. It commonly occurs in association with a systemic or ocular disease, but rarely may develop as an isolated disease. Etiology could be infective, non-infective, neoplastic, or idiopathic in nature. It is essential that a thorough history, review of systems, and physical examination are performed in patients. They have associated complications such as macular edema, vascular occlusion, retinal ischemia, and neovascularization, which can hamper the vision. Here we report a case of unilateral retinal vasculitis in an otherwise healthy male patient. So we have a 44-year-old male patient who presented to the OPD with sudden onset of floaters in his right eye since 5 days. His visual acuity in right eye was 618, improving to 612, and left eye was 6.6. Anterior segment was within normal limit in both right and left eye. On fundus examination, right eye fundus showed +2 vitreous cells, and there was superiorly severe vasculitis with surrounding hemorrhages and sheathing of retinal vessels, with inferiorly a pigmented scar and snowball opacities. Left eye fundi was within normal limit. This is the fundus picture showing superior vasculitis and inferiorly snowball opacities and a pigmented scar. Left eye fundus was within normal limit. The presence of vitritis and vascular sheathing suggested an inflammatory cause. So Mantoux test showed 12 millimeter in duration. Sputum AFB was negative. Serum ACE was 150 microgram per liter. Other blood investigations, chest X-ray and CT thorax were within normal limit. FFA showed in the right eye showed block fluorescence due to retinal hemorrhage. CNP areas were noted superiorly, temporally, and inferiorly. The foveal avascular zone was normal. The clinical findings in the diagnostic test were suggestive of retinal vasculitis secondary to query tuberculosis bar ocular sarcoidosis, and patient was started with a trial of immunosuppressants and oral steroids in the tapering dose. Additionally, a right eye laser photocoagulation was performed. The variation in the clinical presentation and lack of uniformity in diagnostic criteria makes the diagnosis difficult in case of vasculitis. We had two differentials, ocular tuberculosis and sarcoidosis. Ocular tuberculosis is an extrapulmonary manifestation of Mycobacterium tuberculosis infection sarcoidosis is a chronic multisystemic granulomatous disorder caused by an exaggerated cellular immune response to a variety of self or non-self antigens in a genetically predisposed individuals, resulting in non-caseating granuloma. The gold standard for the diagnosis of TB includes detection of MTB in ocular tissues or fluids, whereas in sarcoidosis, it is a tissue biopsy. Imaging techniques available are FFA, ICG, OCT, and adaptive optics, which helps in the diagnosis as well as in guiding therapy. FFA can demonstrate vascular leakage and staining and can be used to evaluate the degree of arteriitis or phlebitis. Perivascular sheathing with variable vitritis is a common finding both in sarcoidosis and tuberculosis. Candle wax drippings are associated with sarcoidosis. Choroiditis lesion, with both active or healed, is a common observation in TB vasculitis. The concurrent use of systemic corticosteroids and immunosuppressants were effective in this case. At 1 month follow-up, best corrected visual acuity in the patient was 6/9 in the right eye with resolving vasculitis. And this is the follow-up picture of his fundus after 6 months, which shows resolving hemorrhages and with no active lesions. Left eye fundus was within normal limit. Conclusion: extrapulmonary TB can present with no previous history of pulmonary infection. Even though it is curable, it is often missed in its extrapulmonary form. Sarcoidosis mostly affects anterior uvea, but always you should keep a differential of tuberculosis in case of vasculitis. The treatment of vasculitis is dependent on etiology. For an elusive etiology, corticosteroids along with an immunosuppressant agent may be recommended. The prognosis is variable. Early diagnosis and management can be of utmost beneficial for the patients. Thank you.
So a few points. When you come to retinal vasculitis in a patient unilateral one quadrant, with just a MAN2 of 12, you don't have a PCR study, you're not sure it's tuberculosis. With just a serum ACE, you're not going to be sure till you don't have an HRCT chest to document your ocular sarcoidosis. A lot of unilateral single quadrant retinal vasculitis can be an idiopathic retinal vasculitis, not without any particular cause in your case. And yes, FFA is important, OCT is important, but ICG has no role.
So you mentioned retinal laser was performed in your case. What was the indication?
It was retinal hemorrhages were there.
The areas are non-perfusion.
Yes.
Okay.
That was the reason for which they did the laser.
Thank you.
So we'll move to the next.
Good afternoon, everyone. I am Dr. Riba Shakil. The topic of my presentation is a prospective study of prevalence and severity of primary open-angle glaucoma in type 2 diabetics. The aim of the study is prevalence and severity of POAG in type 2 diabetics. Other than this, the objectives are relation between duration of diabetes and glaucoma severity to study the variation of intraocular pressure in diabetics. It is a cross-sectional observational study done in 2 years and in a tertiary eye care hospital in North India. The sample size was calculated by this formula, and we got an approximate sample size of around 200. We included patients above 40 years of age. 200 patients we included, type 2 diabetics, both genders, willing to participate in the study. We excluded patients who are not giving consent, who have any other surface disorders, dense cataract, patient with secondary glaucoma or any other type of glaucoma or family history, patients with diabetic retinopathy, all patients with systemic illness other than diabetes or diabetes involving other systemic systems. Now, what has already been done in this topic, they have studied the glaucoma prevalence with duration of diabetes with various glycemic control index and with males gender with increasing age, but they have also included other types of glaucoma, other types of systemic illnesses, and also the cases of diabetic retinopathy. What has not been done is the determinants of diabetics only in relation to primary open-angle glaucoma. There's still a divided opinion between patients whether there is association with diabetes or POG or not, and there are very limited studies focusing only on POAG prevalence. So the need for present study is because there is increasing prevalence of diabetes, around 455 million in today's scenario, and glaucoma worldwide. A less awareness of glaucoma in general population, and mainly the lifestyle and environmental risk factors, they affect diabetes and may also influence POAG. So demographic details, medical surgical history, duration of diabetes, treatment status, glycemic index, random blood sugar level, ophthalmic evaluation including intraocular pressure, gonioscopy, grading of severity based on perimetry severity criteria was done. The results showed that mean age of the population was 54. The male gender constituted 56%, female 44%. When we study the duration of diabetes and glycemic status, we see that mostly the people fall between 2 to 10 years, and the random blood sugar of more than 200 milligram per DL was seen in majority of the patients. Then HbA1c, higher HbA1c was seen in majority of the population, and most of the patients were using oral hypoglycemic agents. And most of the patients were falling between 12 to 20 mm of mercury intraocular pressure, and obviously we are taking open angles, but the severity of primary open angle mostly were falling in grade 2 and grade 4. So with glaucoma and demographics, we see with the increasing age, the red indicates glaucoma. With increasing age, the glaucoma risk is increasing. With male gender, the glaucoma risk increased with the higher IOP and higher cup disc ratio. Then again, the red bar is glaucoma. So with increasing age, with increasing duration of diabetes, the risk is increased. With increasing RBS level, more than 200 increased risk. With the increase in HbA1c, there is increased risk. And with the binary logistic regression shows only HbA1c is a significant, HbA1c level shows a significant association between glaucoma and diabetes. Glaucoma and severity, the red bar shows the higher severity of glaucoma, and it is seen in more duration of diabetes. The severity is seen with higher RBS levels, higher HbA1c levels. And these are the IOP variability what we studied in our study. And IOP variation is seen with the higher RBS levels and higher HbA1c level. So we conclude that among patients with relatively very short duration of diabetes, like in our study, the mean duration was only 5 years, the prevalence came out to be 10.5%. And the total of 19 patients had bilateral glaucoma, 2 had unilateral glaucoma. There's a significant association between higher IOP with the longer duration, higher RBS and higher HbA1c. On univariate analysis, glaucoma occurrence and its higher grade of severity is associated with these glycemic indices. On multivariate analysis, only HbA1c level were found to be significantly associated with glaucoma prevalence. These are my references. Thank you.
You said that stage 3 and stage 4 gonioscopy was there. What gonioscopy did you use, and what in gonioscopy you have given? Go to the in patients.
Grading of gonioscopy. Schaffer's grading we use. Schaffer's grading system.
And what gonioscopy did you use?
We use 3-mirror. Goldman 3. Thank you.
You have shown me one chart. So
Yes, sir.
what is the name of the chart?
Slides.
Last, I think second. Yeah, no, more. Yeah, so what is the name of this chart?
Sir, this is box plot.
Yeah.
Thank you, sir.
We'll move to the next speaker, Dr. Sudha.
Good evening all. Myself Dr. Preeta Sudhakaran, and I am discussing our study on the effects of preoperative steroids in the outcome of phacotrabeculectomy. So glaucoma, it is a chronic optic neuropathy characterized by optic nerve head damage, RNFL damage and loss of function. And trabeculectomy, it's a partial guarded filtration surgery and is most often done along with cataract surgery. Often it fails because of the subconjunctival scarring, and the risk factors being the use of anti-glaucoma medications, multiple, for a long period of time. So when we use long period of anti-glaucoma medications, it will lead to subconjunctival inflammation leading to scarring. So how we can improve means we have many preoperative, intraoperative and postoperative strategies, of which we have utilized the preoperative strategies of using topical steroids and discontinuing topical anti-glaucoma medications. So how steroids helps in wound healing means it inhibits the macrophages, decreases the capillary permeability, increases the fibrin deposition, decreases the fibrin deposition and collagen release. The aim of our study was to compare the surgical outcomes of phacotrabeculectomy in primary glaucoma patients who are treated preoperatively with topical steroids to those who were not treated. And we did a prospective open-label randomized control study at glaucoma services at Aravind Eye Hospital, Tirunelveli. And recruitment period was for 4 months with a follow-up of 6 months. And all patients were on anti-glaucoma medications for a period of minimum of 3 months. 81 patients were recruited and randomized into Group A and Group B. And in Group A, topical anti-glaucoma medications were stopped and started on tab acetazolamide and fluorometholone eye drops for a period of 2 weeks. And in Group B, we have stopped anti-glaucoma medications and just simply started on tab acetazolamide for a period of 2 weeks. All patients underwent phacotrabeculectomy. And outcomes were monitored with special emphasis on IOP control, AGM required postoperatively and interventions required postoperatively. Coming to results, both groups were comparable, and IOP control, post-op IOP control at 6 months was significantly better in Group A, that is the steroid group, and the number of anti-glaucoma medications that were required were almost equal on both groups, but slightly more on Group B, which is not statistically significant. And the number of postoperative interventions required, better IOP control was achieved in Group A with fewer number of interventions as compared to Group B. Coming to discussion, Broadway et al. Have found that stopping anti-glaucoma medication in starting FML have led to decrease in conjunctival inflammation as well as an improved trabeculectomy success. Similarly, we also had a better IOP control in the steroid group in our study. This is again similar to Bruzigam et al., but they did not have a statistically significant difference between the groups. Bruzigam et al. Have found that the number of AGM required postoperatively was almost 0 in the steroid group and 24% in the non-steroid group. But our study had only a marginal difference between these two groups. Lauren et al. Have found that the postoperative interventions had not been very much significantly different between their steroid and non-steroid group. Our study have showed a better IOP control in steroid group with a fewer number of interventions as compared to non-steroid group. So we conclude here that the usage of preoperative steroids improves the success of the phacotrabeculectomy as compared to patients who did not use preoperatively topical steroids. Thank you all.
These were low-dose steroids used, right?
Yes, ma'am. Yes, ma'am. We have used low-dose steroids for a period of 2 weeks.
And you kept a gap of 2 weeks between the surgery?
We started for 2 weeks prior to, we have planned a surgery, and 2 weeks prior to the surgery, we have stopped the topical anti-glaucoma medications. Both the groups are put into acetazolamide.
And lubricants were used?
No, ma'am. The water drops was given to them was stopped except for the steroids was added. Steroids is the only add we have given.
So what was the method of randomization you have used here?
We just randomized, I don't get, we have
What
a
is the method of
statistician
randomization?
who have randomized the patients.
But there are so many methods of randomization. That's what I wanted to know.
It's an open level.
What was the IOP in that case? Did you monitor the IOP when you stopped the anti-glaucoma and just put them on tablet acetazolamide?
Yes, ma'am, but all the patients had IOP was around 20 and 22 in each groups. Preoperatively you are asking, right, ma'am? It was around 20 and 22. It was ranging between 20 and 22.
These patients that you stopped the anti-glaucoma medications were on a single line of AGM or?
No, all were multiple AGMs. At least 2 or 3 drugs were there, and was on a period of more than 3 months. At least minimum of 3 months the patient.
No IOP rise in any?
No, ma'am. Though we have given we have not given taken patients. Though it was a randomized study, we have not actually recruited patients who had a higher IOP, who was not getting controlled with if it is more than 25 and all, we have not recruited. And secondary glaucomas also we have not recruited.
All the patients whom you have started tablet acetazolamide DID for 2 weeks, they were compliant?
They said they are compliant. We cannot actually, that is actually a limitation of our study. We are not able to monitor how compliant, because it causes a lot of gastritis. We have given Pantop also along with that, but we cannot, that is actually a drawback of this study. We cannot comment on the complaints of the patient.
one question. Did you miss out any outcome to be measured? Study any outcome that you can measure? Like, okay, yes, I missed this part. I should have measured this outcome.
Like we have not monitored the field evaluation is not done, sir. Basically because all the patients had a cataract actually. So the pre-op cataract would also inhibit the field evaluation. So we cannot compare what was there pre-operatively and post-operatively with that much. Like some patients, we have not graded the cataract in all these patients. So some patients would have lesser cataract grading as compared to other patients who will have a more cataract grading, which will hinder the results of our field evaluation. So we have not done that. Thank you.
The next
A very good afternoon to our respected judges and one and all present here. Myself, Dr. Neela Priyadashini. My topic is prevalence and its related risk factor of glaucoma among adult patients attending the tertiary care center covering Kanchipuram district, a cross-sectional study. Introduction: the glaucoma can be defined as a progressive neurodegenerative optic neuropathy causing structural as well as functional damage to the retinal ganglion cell, resulting in progressive loss of visual field with or without raised intraocular pressure, resulting in blindness. It is the second leading cause for the permanent vision loss, and it was estimated to be around 65.5 million individuals were affected by glaucoma in 2020, and it may reach up to 80 million by 2040. Major risk factors for this disease include age, race, gender, and family history of the disease. People with glaucoma may show blurred vision, eye pain, headache, and hyperemia with or without systemic disease and medication in case of secondary glaucoma. Glaucoma can be diagnosed based on the sign at the time of examination. Examination with slit lamp microscopy, tonometric measurement of intraocular pressure, evaluating the structural effect of intraocular pressures on optic disc with imaging helps to confirm the diagnosis. Need of the study: glaucoma has been termed as the silent thief of sight, as the visual loss occurs gradually over a long period of time and symptoms occurs when the disease advances. Glaucoma is one of the preventable causes of blindness. Glaucoma shows 50% of the patients affected with glaucoma is unaware of the disease. Awareness of glaucoma will help in early diagnosis, management that can prevent severe visual loss and visual field defect. Objective of my study include to determine the prevalence of glaucoma among adult population, to identify risk factors associated with the glaucoma among the study group. Type of study: it's a hospital-based cross-sectional study of population more than 40 years of age people attending Opthal OPD, which is from March 22 to February 2023. It is a place of study. It's occurred in tertiary care center covering population of 30 villages of Parandur block, PHC, Kanchipuram district, Tamil Nadu state in India. It's a study tool, a pre-tested and pre-designed questionnaire for assessing the risk factor. Inclusion criteria include age group of above 40 years of age, patients willing to participate in the study. Exclusion criteria: patients with eye infections such as conjunctivitis, keratitis, uveitis, scleritis, and also with perforating injuries, foreign bodies, and corneal opacities. Sample size was calculated with prevalence of 4% and precision of 10%. It is estimated to be 68. Methodology: after getting an informed written consent from the patient, the questionnaire was distributed to collect the necessary data on the socio-demographic variables, past history, medical and post-ocular history, followed by ocular examination with intraocular pressure measurement. My research shows the association of some socio-demographic factors with glaucoma, which include significant results with age and also significant results with family history of glaucoma, hypertension and diabetes, and intraocular pressure. In my study, the prevalence is of about 24%, and the clinical subtypes of glaucoma include primary open-angle glaucoma, primary angle closure glaucoma, and secondary glaucoma, of which primary open-angle glaucoma seems to be most common type, which include 43.80%. These are the other parameters. My discussion: from this study, we found that the overall prevalence of glaucoma is about 24%, which is similar to the study conducted by the Hubert et al., where he found the prevalence is around 26%. The study conducted by Hasan also shows the prevalence is 4%, which is very low, and contrast to our study report. This is maybe due to the sample size selection. In the present study, we found that age, intraocular pressure, comorbidities like diabetes, hypertension, and family history shows significant, which is similar to the study conducted by the Garudadre et al. Another study of Nagnavi et al. Shows that the glaucoma with association with old age and high blood mean pressure, which is also similar to our study report. In this present study, we found that primary open-angle glaucoma is the most common subtype, which is also coded in another study, Jacob et al., where he also coded that it is of 40.1%. Conclusion: the prevalence of glaucoma was considerably high among adult population. Major risk factors confirmed by this study include family history, older age, high blood pressures, and comorbidities. And primary open-angle glaucoma seems to be the most common subtype glaucoma detected in this study. Therefore, increasing public awareness about the identifiable risk factors of the early detection of glaucoma and preventing visual loss and visual and field loss. These are my references. Thank you.
Just one comment.
Sure.
So when you prepare the PowerPoint, so you have shown so many references as a uppercase. So I don't see any references downstairs. So you be careful when you prepare the slides. It shouldn't be clustered in the sentence formation and the ratio between the heading and the contents. So next time, so you can think of
We can code in last
and
slide.
contrast. There's so many things when preparing the slides PowerPoint.
Sure,
so
sure.
you can consider that.
I'll
Thank
cut it
you.
next.
Yeah,
Thank you.
okay.
Easy actually. Yeah, you have to clutter.
Yeah.
And it's a prevalence study, but you have not mentioned important prevalence study which was done. Chennai glaucoma.
Aravind High Hospital has done a prevalence study, sir, which include which was the only study which is in South population, South Tamil Nadu population, which was studied.
Chennai glaucoma study.
Sir, Chennai, South Tamil Nadu population, which was also. Along with that only, I calculated my prevalence study.
The glaucoma is in the country is also increasing.
Sorry, it has become an economic, it affects our national growth also, sir, because it is estimated to be increasing by 2040. By screening, having a lot of campaign and all, we can prevent that undetectable cases. Unfortunately, 90% of the cases were undetected, and it is mostly occupying above 40 years of productive age group. It will affect our economical side also in a long picture. So it is very important, crucial time to early detection and timely treatment to prevent this study.
Thank you.
Thank you.
Shown in that study that not only in the rural population, in the urban population
Yes,
also
sir. Since my college is situated there, I made a study. In long term, future study, I'll make it as a big population. Thank you. Thank you.
Should plan for a community-based study as well.
Good afternoon to everyone. So I will be presenting on IgG4 related orbital disease presenting as optic neuropathy, a rare presentation. So IgG4 related disease is an autoimmune condition which is associated with plasma cell infiltration in various organ systems and elevated serum IgG4 levels. So middle-aged and the elderly males are commonly affected. Orbital involvement with mass lesions have already been reported in the literature, but there are very few reports on optic nerve neuropathy associated with IgG4. So we wanted to report a case of IgG4 related orbital disease which presented to us with optic neuropathy. So a 78-year-old gentleman presented to us with sudden diminution of vision in his left eye, which was noted 5 days back. His vision was counting finger 1 meter N36 with a relative afferent pupillary defect and a defective color vision. Right eye was normal. He was pseudophakic in both the eyes. Dilated fundus examination showed in the right eye small optic disc with essentially normal fundus, whereas in the left eye the optic disc was hyperemic. Macula and periphery was okay. Ocular movements was full in both the eyes. So we did a blood workup and he had uncontrolled diabetes mellitus, RBS of around 300 milligrams per deciliter. So we considered a possibility of anterior ischemic optic neuropathy and we referred the patient to physician for urgent control of diabetes mellitus, and we ordered an MRI brain with orbital cuts to rule out neurological causes. But unfortunately, he was lost to follow-up and he came back to us 2 months later with left eye complete ptosis, proptosis, and complete limitation of ocular movements in the left eye. His visual acuity has dropped to perception of light with inaccurate projection of rays, with persistent RAPD, defective color vision, and dilated fundus examination showed a combined central retinal artery and vein occlusion with a cherry red spot. Right eye was normal as before. So when a clinical diagnosis of orbital inflammation suggestive of orbital apex syndrome was made, which was confirmatory on MRI. So on MRI, the key features were pachymeningitis, left proptosis, and a lesion encasing the intraconal part of the optic nerve. So we gave the patient 3 doses of intravenous methylprednisolone, 1 gram per day. Still, he had minimal improvement. So we did the workup for infective, inflammatory, and metastatic causes, and raised serum IgG4 was noted. So we did an incisional biopsy through a lateral orbitotomy, and histopathology was confirmatory. It showed dense lymphoplasmacytic infiltration, IgG4 positive plasma cells, and typical storiform fibrosis seen in IgG4 related disease. So on 1 year follow-up, patient is on immunosuppressants. Visual acuity is unchanged, but he has significant improvement in proptosis and ocular movements. So I stated before, there are very few reports which have reported optic neuropathy as a primary presentation. Our patient also presented with all features of optic neuropathy, but probably he has a clinical deterioration with visual loss due to immune-mediated inflammatory process. So we wanted to emphasize on the importance of early diagnosis, which can prevent the visual damage. And IgG4-related disease can present as optic neuropathy, which can be an early manifestation of orbital involvement. So a high index of suspicion, timely imaging, and close follow-up is very essential for preventing visual damage in these patients. These are my references. Thank you.
The patient also has a diabetic, uncontrolled diabetes.
Yes, sir. Yes. Slides.
What is the reason why there is a high IgG4? What is the level of IgG4 level in that patient? Did you measure?
It was quite high, sir. Like quite high. So when he presented to us, he had the clinical features of optic neuropathy. He had a defective vision. He had an RAPD with defective color vision, and he had an hyperemic optic disc. And he was not aware he was diabetic. So when we analyzed and did a workup, we came to know that he has diabetic, and his RBS was around 300. So we considered a possibility of anti-ischemic optic neuropathy, and we referred him to the physician. But at the same time, we never left him. We advised an MRI, but he was lost to follow-up, sir. And the visual progression, the deterioration happened very drastically within 2 months. That's why the vision dropped to 1 meter. So probably the clinical deterioration was because the immune-mediated, the autoimmune-mediated inflammation, which progressed to involve the orbital apex, and he had a drastic deterioration.
IgG4 related disease because the patient has other problems also. That's what I'm thinking.
Yeah. But histopathology was very diagnostic, ma'am. That's why we were conclusive that it is IgG4. It had a typical plasmacytic infiltration with storiform fibrosis. So that made us that that would have caused it. Yeah. Yes. Yes.
Was the lesion involving the muscle?
Yes, ma'am. I didn't get it.
The part from which the biopsy was taken?
Yes, ma'am.
From where it was taken? Was it involving the muscle or it was in the intracoronal space?
From the mass, that mass was there, ma'am. MRI was suggestive of a encasing mass. So we took a biopsy from that. Okay, thank you.
The next speaker is...
Good afternoon, judges and the audience. I present here a unique case of lens coloboma, which was a rare manifestation in congenital rubella syndrome. So ocular coloboma is a well-known entity with an estimated prevalence of 1 in 10,000 world population, which is due to failure of closure of embryonic fissure at either end, which results in a spectrum of corneal, iris, ciliary body, or choroidal, retinal, optic nerve defects, depending upon which end of the embryonic fissure fails to close. Coloboma of the lens is characterized by notching of the equator of the lens in any quadrant, usually occurs as an isolated anomaly or bilaterally in association with colobomas of the uveal system. So lens coloboma is due to defects in the zonules and ciliary bodies during development, and congenital rubella syndrome is has a multisystemic involvement, and most of the ocular structures can be involved during the in vivo development of the fetus because of the virus. It has many ocular manifestations. Most commonly, cataract, microphthalmos, and iris hyperplasia are reported and are a common combination to present in majority of the cases. Other systemic associations could be hearing loss, cardiac anomalies, neurological anomalies, hepatosplenomegaly. Our case was a 4-year-old child. Informant was father, and they presented with history of white reflex in both the eyes since 2 months of age. Her birth history was uneventful, and the development history was also uneventful. On ocular examination, the visual acuity of right eye was just following light, and the left eye was not even following light. And in this figure, we can see that there was a total cataract in the right eye, and the pupils were poorly dilating, although there were no phacodonosis or iridodonosis present in both of the anterior segment. In the left eye also, there was total cataract. On systemic examination, there was microcephaly. There was no developmental delay or neurological deficits, and cardiovascular workup showed patent ductus arteriosus and mild pulmonary arterial hypertension, and the sensory evaluation for hearing loss was not there. On B scan, the axial length of the right eye was 28.85, and the retina was on, which was anechoic, whereas in the left eye there was a retinal detachment seen, and the axial length was 22.77 millimeter. So we diagnosed it as a clinically confirmed congenital rubella syndrome, and the child was planned for right eye aspiration with IOL implantation. But on table peroperatively, a lens coloboma was noted in the temporal quadrant, and due to the poor zonular support and the lax and calcified anterior capsule, only lensectomy could be done, and a secondary scleral fixation of the IOL was planned. On post-operatively, fundus examination was done, which showed a tessellated fundus with chorioretinal atrophic patches. In the post-op course, after 1 month, the child came back again with a sudden diminution of vision for 3 days, and on examination, there was a right eye total rhegmatogenous retinal detachment, for which pars plana vitrectomy was done with silicon oil tamponade with endolaser. And the final post-op best corrected visual acuity till now follow-up is 624. So congenital rubella syndrome may present with a wide spectrum of ocular and systemic findings, and effects is during the early gestational period, and toxic and inflammatory genetic factors may be responsible for the weakness of the zonules. And associations are seen, reported in Marfan's and Marshall syndrome, and in bilateral cases, there is always associations of other uveal colobomas. So ours is the first case report of unilateral lens coloboma in a patient with congenital rubella syndrome. So any infant with unilateral or bilateral cataract should be investigated for congenital rubella syndrome, and the possibility of lenticular coloboma should be kept in mind for the planning of the surgery. Thank you.
Any antenatal history that you took?
No, sir. There was no history of fever or rash, nothing from the mother. There was no history given by the mother of such infection.
Any rubella, IgG, IgM titers for the mother?
Ma'am, only IgG, but that is because of the vaccination. So it was positive.
No, but you're kind of.
It was clinically, actually, not lab proven congenital rubella syndrome, but clinically proven, because in the classification for the diagnosis, we have a suspected case, then clinically proven case, and then comes the laboratory case. And in infants after 1 year of age, it is very difficult to diagnose it with IgG or IgM antibodies. So that is why. Thank you.
So we'll call the absent participants once more.
Information sentence in a slide in PowerPoint, so please avoid sentence form of writing. So it should be a bullet points. And presentation, of course, your time limitation, and the slides, as I said, and originality is okay, but there are certain issues that while preparing the PowerPoint for research. So always think of about what is the research question? Because nobody talk about the research questions for a scientific research, because for case presentation is okay. So So research question is a very important point, and the sampling, because most of the hospital-based study, there has to be some kind of technique. You should mention the sampling, how my recruitment should be done. So there are techniques. So you can read it about it. The hospital-based study, recruitment, how the recruitment should be done. Thank you.